Hello, this is Jamie Stevens. I'm with Centris Health. I want to thank you for joining over this noon hour for this presentation, which is an overview of a general risk adjustment. And then we're going to talk about a pulmonology and a neurology focus. So a couple different items here. If you have questions as we go along, feel free to type them into either the chat section to everybody or to myself, or there's also a questions tab that you'll see. And as I go through, if I see questions pop up, I'll take some time as we go along to answer these questions. The presentation will be broken into two different sections. The first half will be just a general review of what risk adjustment is. Some of you may have familiarity with this, whereas other people this may be new to. So I'll talk a little bit about how risk adjustment is relevant to how we get paid and practice today. And then the next half will be spent looking at specific codes around pulmonology and neurology focus, and discuss how we can use those and some documentation tips that go along with that. So this presentation is hosted by Centris Health. For those who aren't familiar with Centris Health, I wanted to first give a little bit of background on what Centris Health is and let you know how your healthcare organization or your practice is affiliated with Centris. Centris is a clinically integrated network, which means we have a degree of shared contracting and incentives based on our ability to improve the overall health for our patients, and really focus on doing this at the highest quality and the lowest reasonable cost possible. We do this by sharing clinical and quality information in an effort to have a more seamless care delivery model across the entire continuum in the Kansas City area. Centris Health is comprised of more than 1,600 physicians. These are physicians represented by the employed medical groups of North Kansas City Hospital, Advent Shawnee Mission, and the University of Kansas Health System. As part of Centris, there's also many independent physicians, including those affiliated with the Kansas City Metropolitan Physician Association, also known as KCMPA. Currently, Centris Health has major contracts in place with all of these systems collectively work towards with Blue KC, Aetna, and with Medicare through the Medicare ACO agreement. So I'll begin by just providing a general overview of what risk adjustment, or I'll refer to it at times as RAF, is and why we should focus on it, as well as how our current payment models are dependent on our ability to appropriately risk adjust our patients. And when I say that, what I mean is the way that we code patients and assign diagnosis codes really is a way to inform the payers of what the patient's health status is, what recurring conditions these patients have. And from that, they're able to calculate what they anticipate the cost of care to be related to those patients. So Medicare and other payers use different models to assign risk adjustment scores to various ICD-10 codes. These ICD-10 codes with their assigned risk value are cumulative in nature. So the more diagnosis that the patient has that's risk adjusted, the higher the relative RAF score is. So in order to determine the patient's RAF score, the patient's health status has to be redetermined each year. So starting in January, a patient is assigned an age and demographic score. And as a patient is seen by various providers and clinicians throughout the year, and documentations are captured and reported, that adds up to an average risk score that patient has at the end of the year. So to do this, the patient has to be seen at a face-to-face visit. The provider has to assess, treat, and document the RAF diagnosis in the medical record. And then that record has to get to the billing department for each system or office. And the billing process has to have some reliability that the risk-adjusted diagnosis will find their way on a claim, as that's the only way that it's reported to Medicare or to the payers. So if there's certain limitations that billing departments deal with, sometimes it's a limited number of diagnosis that can go on the claim. Sometimes it's just that there's so many different diagnoses that get reported on the visits. I know some of these patients have 10 or 20 different diagnoses. So being able to pick out the ones that are relevant, the ones that are being addressed at that visit, and capturing the ones that haven't been dealt with yet in the calendar year are all challenges. And we'll talk a little bit about how we can maybe manage that as we go along. So this model really places a high importance on documenting and coding all conditions that the patients have whenever a patient's being seen and when we have the opportunity to do that. So these diagnosis codes are then used to determine what the expected cost of care for each patient is. Generally, the higher the RAF score, the higher the anticipated cost of care. And as that anticipated cost of care rises, it creates an opportunity that shared savings may be able to generate. So the way shared savings models generally work is if we meet certain quality indicators and certain quality benchmarks, if we're able to provide effective, high quality care at a certain amount that falls below what the anticipated cost is, there's opportunities that difference, we're able to collect some shared savings. And that goes back to support the clinicians, implement systems, and so forth. So this next slide is going to show a couple scenarios on how risk adjustment impacts the determination of how much it's expected to cost to care for a patient with various cost differences. So this slide shows an example of how shared savings calculations are impacted by RAF coding variations. The three boxes that you see here represent the same patient, and it is meant to call out how coding variations impact the patient's risk-adjusted score. So in these examples, it's the same patient. It's a 76-year-old female. This patient in the past has been diagnosed with depression, cardiomyopathy, COPD, and depression, and morbid obesity. So we're going to assume this is a Medicare patient. And in the Medicare model, this patient is assigned a risk-adjusted value associated with their age and gender. So the first line on all these boxes you'll see is a 76-year-old female, and in each case, it's assigned a age and gender risk-adjusted score of a 0.452. So based on this, just the age and gender risk-adjusted score, anything additional that's captured onto this patient's diagnosis will add to that cumulative base score. This model assumes that the average health of a Medicare patient is a risk-adjusted average of a 1.0. So across all Medicare, each year they annualize it and say a 1.0 is the average health of the patient. And in this example, we're going to assume that the average health patient of 1.0 would cost Medicare $700 per month to deal with each patient. So if you look at the red box on the right, it shows what happens if the patient has these diagnoses, but none of them are captured through a face-to-face visit and reported on a claim in the calendar year. So you see the patient has depression, cardiomyopathy, COPD, morbid obesity, and the average RAS score remains the 0.452 because none of those codes were captured. So maybe this patient was only seen a couple times in the year for acute issues. Maybe they had a sinus infection and none of these issues were addressed. So this would keep the patient's risk-adjusted score according to the provider or the payer as a 0.452, and the anticipated cost of care for this patient with that risk-adjusted score would only be $316 per month. So if this 316 includes any costs that may come up related to emergency room visits, lab results, or lab tests that are done, imaging, face-to-face office visits with providers. So all of the care has to be managed within that budget based on what the insurance plan knows about this. And given what we know about the patient's complex medical history, it'd be very difficult to come in under that amount. So the yellow box in the middle shows what happens when some of the diagnosis codes are captured. So the patient had a major depressive disorder, single episode, unspecified. So the patient has depression, but this provider chose a risk-adjusted or a diagnosis code that was not specific enough to assign the risk value. And sometimes that matters and sometimes it doesn't. With the case of major depressive disorder, if the provider would have specified that this was mild or in remission, it would have increased the patient's risk-adjusted factor. But in this case, that wasn't done. An unspecified code was used and no risk credit was provided. This provider coded the cardiomyopathy, which increased the risk-adjusted value by 0.337. You'll notice that this was an unspecified code that was used, but it still had a risk-adjusted weight. So sometimes it's unspecified is acceptable from a risk adjustment perspective, and sometimes it isn't. Certainly your coders that work with you in your systems would appreciate as much specificity as possible. So whenever you have the opportunity to be really specific, that would help. In this example, the COPD was not captured, but the morbid obesity was, so that increased by 0.262. So this patient's total risk-adjusted value with some of the diagnosis captured increased to 1.051, and their monthly anticipated budget increased by up to $736. So it's slightly above average of what they expect and slightly above average with the anticipated budget. So if you see on the far left, this shows what happens if all the codes were captured. So the major depressive disorder was properly coded, the COPD was captured, and you'll see that since this patient has a congestive heart failure as well as COPD, an additional disease interaction of a 0.19 was added. So this increased the patient's RAF score up to 1.876, so much above average, and the total budget for managing this patient is up to $1,313 per month. So when you look at how the different coding practices impact the anticipated cost of care, the monthly budget of this patient increased by almost $1,000 per month from the red scenario to the green scenario, which is equal to about $3,800 a year, going from $3,800 a year to almost $12,000 a year to manage this patient. So managing this patient with an anticipated budget of around $12,000 is much more likely than to manage this patient with a very low budget. If there's any questions on this, feel free to stop me as we go along. So as I mentioned on the previous slide, some diagnosis categories, when found together on the same patient, are awarded additional risk adjustment credit. This table shows some of the groupings together that if these conditions are found on the same patient, additional RAF is credited due to the complexity of managing these patients. For example, if a patient has an immune disorder and cancer, they give an additional RAF value of 0.892, which is a very high amount. It shows the complexity of co-managing these conditions together. And if you look at CHF and CHF along with diabetes, COPD, or renal issues, somewhere between a 0.182 and a 0.27 additional RAF is added on. So whenever possible, being able to code these, capture these diagnosis codes that are common and report it ideally on the same encounter to show that that's part of your medical decision as you go through is great, but at least once during the year, capturing this information as we see patients is important. All right, so for these remaining slides, we're going to look at some of the most common diagnosis, and we'll first look at ones associated with pulmonology, and then we'll look at some neurological codes that are commonly seen in neurology practices. And I'll kind of call out some things of what to look for, maybe some recommendations if you're coding and documenting these charts, but I also wanted to point out the risk-adjusted value. So there's tens of thousands of ICD-10 codes that are risk-adjusted. Certainly most of those we aren't used. So I'll show what the risk-adjusted value is for the main grouping, and then you can look at what your common practice is and what the codes are that you routinely use in your practice. And I'll also point out some common codes that we see that aren't risk-adjusted, but maybe have a more appropriate code that you could use to risk adjust your patients. So this next slide is looking at COPD, which is kind of a grouping of a bunch of codes that we look at. When we're seeing these, it's COPD, emphysema, chronic bronchitis, obstructive asthma are the most common ones. And when we document this patient status, we really want to look as whether it's chronic or acute. So if these are chronic COPD type diagnosis, and we capture that, it's risk adjusted at a 0.336. I think most pulmonologists are fine with capturing this. This is a highly commonly used code at primary care as well. I think a lot of times we see people coding asthma, which is not a risk adjusted code, or I'll show on the next slide with pneumonia. But coding COPD and capturing, even if it's simple chronic bronchitis or COPD with acute lower respiratory infection, those are the common ones that we see, and we want to capture that whenever possible. So pneumonia is another commonly used diagnosis. We often see that patients will be coded with this, with pneumonia unspecified, which is J18.9. J18.9, pneumonia unspecified, is not associated with a risk-adjusted value. So if If the provider sees a patient with pneumonia and codes whether it's an organism or bacteria and indicates the location, it turns that code into a risk-adjusted code, and it's at a risk-adjusted at a rate of 0.131. So lobar pneumonia, unspecified organism, J18.1, is a commonly found diagnosis. It's the bottom one on the top table there. So if people were specific and called out the location on that, I think there's many instances that a non-risk adjusted code could be increased and a more appropriate, more specific code that carries risk adjusted weight could be associated. If patients are on ventilators and they have pneumonia, whether it's inhalation or if it's or an aspiration pneumonia or if it's ventilator associated pneumonia, there's specific codes for that. Those codes are risk adjusted at a much higher rate. So the ones that fall into this HCC 114 category, that's a separate category than the HCC 115. So if you have a code, I should explain this a little bit. If you have a code that falls into one HCC category, so say it's the 115, if you pick 2 or 3 diagnoses from the same category, you really only see the risk adjustment cumulative value one time for that. But if you choose it from different categories, so maybe it's a diabetic code and a neurologic code, those ones are compounding. So as long as they fall into different categories, it gives us an opportunity to get that cumulative value for those risk-adjusted codes. So this next slide is to do with cardiorespiratory failure. So many patients with long-standing COPD have chronic respiratory failure. Typically, patients with chronic respiratory failure require supplemental home oxygen therapy. So a diagnosis could be considered for any patient using home oxygen. We often see the code Z99.82, which is dependence on supplemental oxygen, is a common way to code, and it's a generic code used to capture oxygen dependency. However, this is another example where there is no risk-adjusted value associated with that. So if you use these J96 codes showed at the lower table, acute or chronic respiratory failure with hypoxia, that is an opportunity that you could evaluate and document and assign a risk-adjusted value for a patient that might be a little bit more appropriate to use. If you do that, it takes it from a non-risk adjusted code to a risk adjusted code of 0.282. Okay, and there was a previous question from the last slide that the organism is rarely ever known what that is. So even if you are able to use unspecified organism, that's the most commonly one that we see. It still allows for that risk adjustment. So I mentioned before that unspecified codes sometimes are fine and sometimes are not. In this case, since it's lobar pneumonia, unspecified organism, that would be appropriate to use even if you don't know what the organism is. I hope that answered your question. Yes, location and if it's some kind of organism, that's a key term. Thank you for the question and the clarification. And I think this is something that most commonly would be used for most pneumonias as we see them. I'm not a clinician, but a lot of the content on these slides were managed by meeting with various specialists and going through the claims and determining what stood out as potential opportunities, and we wanted to pass that along. So we're going to talk a little bit about ischemic and unspecified strokes. So CVA codes should be used for only in acute diagnosis. We're kind of shifting a little bit more towards a neurological focus here. So CVA codes should be used for acute conditions. These codes are really only most appropriately used during the stay of a hospitalization, so in an ER or if somebody is admitted. After the patient is discharged, after the initial event, the correct way to document this is coding as a history of CVA. So this is a little bit more cautioning people towards not overusing a risk-adjusted code when it's not appropriate. Previously, we talked about what are some appropriate risk adjustment alternatives. This is one that really we see being used, but probably is not the most appropriate setting. So ranges, when it is an acute onset, the ranges of the codes that are most commonly used are seen in the table below. If you use these outside of that clinic, it probably isn't the best. There's a separate diagnosis if it's a past history. So personal history of cerebral infarction without residual deficit, that's a Z86.73. That's the one that's going to be used when you see patients in the follow-up clinic, or if you see them as a primary care clinician on an ongoing basis, if there's no past long-lasting effects of that. This next slide we'll talk about if there are effects. So this category 169 codes shown in the table below are risk adjusted at a 0.46. So these contain codes related to the sequela of a cerebrovascular disease. So this is a residual effect of an acute phase of the illness, even after that kind of episode is ended. So if we see this for hemiplegia or hemiparesis following a cerebral infarction, that's when we would be able to use that. So if somebody still has limited response afterwards, that'd be appropriate to use. What we oftentimes see associated with this is people will just use muscle weakness generalized, which is M62.81. I would encourage you to get familiar with these codes down below. There could be opportunities that you can use that. And hemiplegia doesn't have to be a complete paralysis. It could be just loss of weakness or loss of strength or limited mobility on that side. So it doesn't have to be absolute. It can be varying degrees of that. So this next slide, paraplegia and quadriplegia. I only bring this up because it gets it's understandable how some of these codes would be missed. I think most clinicians don't think of coding on a calendar year, and if they recognize and acknowledge that a patient's a quadriplegic or a paraplegic, it seems, I get why you wouldn't continually report that code, because that's not going to change. That's kind of a constant effect that this person's going to have, and reporting it over and over again doesn't have much utility in managing that patient. But from a risk of adjusted perspective, since this needs to be recaptured on an annual basis, it has a big impact on assigning the value that this patient is going to be managed, and it really sets a complexity. So if you look at the risk adjusted scores for somebody who's a paraplegic, it's a 1.094, quadriplegia is 1.3. And these are among the highest risk-adjusted scores that are available to use. So if you have a patient who comes in a wheelchair or is a quadriplegic, certainly at least one time for a year, include that on the assessment and make sure that it gets associated with a claim. That will really increase that patient's risk-adjusted value and really give the system credit for the complexity of that patient. Talk a little bit about the neurological complications associated with diabetes. Diabetes is the most common risk-adjusted diagnosis that we see across all the Centris data. If it's a controlled versus a diabetic patient with complications, the risk adjustment is pretty different. So if it's a patient who has no complications and has diabetes, the risk-adjusted score is a 0.106. If at least one complication is captured, that risk-adjusted score almost triples and goes up to a 0.307. So a lot of times when we look at primary care practices, and if there's endocrinologists or coders that code for endocrinology here, oftentimes at a primary care level, we see a way overuse of the diabetes without complication. We have a lot of claims data on providers, and we look at trends, and we see some providers who have very few complications, like maybe they'll see 100 patients with diabetes without complications and 2 or 3 with complications. So overall, there's a general belief that we're probably not coding these diabetic patients as specifically as we could. So if it gets to an endocrinologist, endocrinologists are excellent at capturing all the complications, and I have no concern that we're missing many opportunities with that. Sometimes we'll see them coding 3 or 4 different complications on their visit, which is great. So in a way to help the primary care providers accurately capture that, especially if they're not being managed on an annual basis or coming in frequently to see the endocrinologist, is Be specific on the notes that you send back to them with the assessment and the diagnosis. If you work at a system that has a shared medical record, like I think KU has the same medical record for outpatient as well as inpatient. I think North Kansas City and maybe Advent are moving in that direction. By maintaining a good problem list and replacing codes that aren't accurately reflecting what's going on with that patient, problem list management and maintenance is the best way to recapture these codes and perpetuate them year after year, especially chronic conditions that aren't changing. Maybe they'll improve, but they're probably going to be on there for a while. So the codes most relevant to diabetes and neurologies are the neuropathy, polyneuropathy. All the diabetic complication codes are risk adjusted at the same level. Like I said, I don't have terrible concern that people are missing this at an endocrine level, but it's certainly an under-assessed code at a primary care level. So morbid obesity is a major one as well. This is a highly coded complication. There's a couple nuances that I wanted to point out as we go through this. So morbid obesity is defined a couple different ways. One is having a BMI greater than or equal to 40. The alternative way of looking at being able to code it is if they have a BMI that's equal to or greater than 35 with other severe obesity-related comorbidity. So that's to say that if a patient has diabetes or a patient has hypertension or any chronic disease that may be exacerbated by the effects of obesity, that would include somebody that has a BMI from 35 to 40 as being eligible to be coded as morbidly obese. So comorbidity and morbid obesity must be diagnosed and included on some claim to capture that. So it's best if you're seeing the patient, they have a BMI of 36, but they also have diabetes, coding those two and submitting on the same claim would be the best way to do that. And there's a couple different ways to report diabetes. So one way is to just use the E66.01 morbid obesity due to excess calories. People are traditionally submitting that when the patient's BMI is 40 or greater. So if you want to capture morbid obesity with somebody that I explained had diabetic or some other comorbid condition, but their BMI isn't quite at 40, it's important to explicitly use that E66.01 to call that patient morbid obese on the claim. Another way is a lot of times systems and clinics may have the coders automatically do this. I know Blue Cross had a big push in the last year and a half to capture BMIs on every patient. There's these Z codes, Z68 codes that stage the patient's BMI. So if it's a BMI of 57, they'd use Z68.42. So in some cases, the provider may be coding that, but that's oftentimes something too that is caught at the billing office. And if billing offices aren't capturing these codes, it may be something you want to consider if there's a reasonable workflow to incorporate that into what you're doing. So this next slide has a little bit to do with documentation that supports risk adjustment. So there's a ton of ways that you can document different things. And the intention of this seminar or this session isn't to direct people how to code. It's rather just to try to help raise some more awareness about how the risk adjustment model works and provide some guidance around what our data tells us about the prevalence of various codes. Each organization, I'm certain, has standards in place that provides guidance on how to appropriately document different diagnosis codes to ensure that the notes that you produce and support the use of the risk adjustment codes that you're choosing. So this table shows some examples of what elements should be included in your note in order to provide documentation to support the use of this code. So in risk adjustment and when audits happen and people review charts, the acronym of MEET is often used as a way to simply provide the right types of elements in your note to make sure that it supports the risk adjustment coding. So MEET stands for evaluate or monitor, evaluate, assess, and treat. So for example, if you have a patient that has diabetes, you would monitor it by stating whether the patient was stable, if the patient is testing at home, those type things. To evaluate, you could cite how the patient's blood sugars are running. You could assess by providing counseling or reviewing records. So maybe you're reviewing the records from the primary care provider, or if you're a primary care provider looking at endocrinology consults or other consult notes that are coming in that may affect that patient's condition. And you'll treat by making medications changes, adding new medications, making referrals, or anything that falls into your plan under your treatment. So really, this is just a brief way to look at what are the elements that we want to try to have some kind of coverage on this. I'm not saying everything that's on this screen needs to be associated to every diagnosis that you see, but certainly talk with your coders, talk with the people in your compliance office, and if you have opportunities to participate in just chart reviews and audits, it's a good opportunity to make sure that you're not over documenting, but that you're also not under documenting. I have an appreciation that physicians didn't go into medicine to become experts in coding, nor do they have a tremendous amount of extra time to spend on capturing all this information that goes along with that. So really understanding what's the threshold that you need to meet to code this and have compliance with what you're doing. That's really where you want to go to and make sure that you're getting the right amount of documentation on the right diagnosis. So as a general overview of risk adjustment factor, a couple things that I just want to point out. I think I mentioned it earlier, managing a problem list is the most impactful way to keep codes updated and be able to recapture them on a year-over-year basis. I think the best performing groups that focus on risk adjustment kind of have a team approach to that. So as new records come in, the clinical staff will add consult notes or notes from outside sources that have been diagnosed in the past, make sure they're on the problem list. If there's stuff on there that really doesn't need to be, so if a patient has a cough or they got seen for an acute problem, that stuff doesn't have a place on the problem list. So just thinning it down to the most relevant, important chronic disease codes and making sure those are as specific as possible really helps, goes a long way with that. And then the providers involved in updating that, making sure it's accurate and working along with that. Some organizations do a pre-chart audit, so sometimes this is in the billing office to find out what patients are coming in, what has been coded in the past, and what are the chronic disease codes that still need to be captured for that calendar year. But it could also be achieved just by looking at when the patient comes in, if there's quality measures and things that are outstanding that we know that we need to do. Doing well on quality often also equates to doing well on risk adjustment. So it shows that we're treating and managing complex diseases when patients come in. We're doing that for all the problems that they have. And when we do that, we typically capture the codes that we want to use for that and report that to the plan. So it's good quality and it also provides the right amount of documentation and support for complex chronic diagnosis. Sometimes, depending on your specialty, you may get reports from health plans that show maybe patients are past due for A1Cs or other things. So using reports to recall patients, whether it's internally created or by outside entities, will help to kind of identify patients who maybe haven't been seen. So if they haven't been seen, they haven't had an opportunity to have risk adjustment codes assigned. But then it's also, if you get that A1C and it's an 11, then it's a opportunity to intervene, maybe keep that patient from becoming worse, and it also captures risk adjustment codes. I think also having a relationship between the coders and the providers helps a lot. I've seen organizations that will do quarterly meetings with their coder and their physician or mid-level provider, but also include that person's nursing staff, or if you have a scribe, include the scribe, so that the coders really have a good understanding of what the trends are that the provider is doing. So if a provider is routinely missing documentation for certain codes, or if the provider is always coding just the generic obesity code that's not risk adjusted, it's an opportunity to kind of exchange information. Maybe the provider could explain to the coder why they do things a certain way, and the coder could offer suggestions. So I think it's really important that the coders and the clinicians work together. They understand what each other are doing and kind of create some opportunities for discussion about how to improve that and how to stay on track. The other thing too is there's thousands of codes that we can work on. If you look at your specialty, and we can certainly help to produce some ideas for this, and I'm sure your internal team has ideas as well. But if you look at your what your patient practice is, and you have maybe 3 or 4 codes that you think are underrepresented, or you know that you're probably not capturing document on a regular basis, just pick 3 or 4 codes at a time to work on. You don't have to take it all on at once. Once you get them, you become aware of it. Your clinicians get aware, your nursing staff get aware of it. You implement some practice to improve on the accuracy, and then you move on to a couple more. So it doesn't have to be an all or nothing or all at once. I think incremental improvements in this area really go a long way. So this is the last slide that I have here. I hope that we were able to kind of discuss how these risk adjustment models impact how we're going to be paid now and be successful under payment models. This stuff is happening now. These quality and shared savings-based contracts are really here to stay. They took a while to get started, but now really it's a dominant part of what everybody does. And really our ability to be successful under it has a lot to do with risk adjustment and being as accurate as we can with that. I encourage you to become familiar with your common risk adjusted codes. Centris has some tools that we're going to release here shortly on our website that could be available to all clinicians that will provide kind of a pocket reference guide for codes that are commonly used, and it might be a quick way to look at it to see what codes you might be able to focus on. I really encourage you to understand what the documentation requirements are for your visits, and kind of at least be aware that it's on a calendar year basis. So really being mindful to see patients on a regular basis, capture the diagnosis as frequently as you can. Work as a team around problem list management, especially if there's a shared chart involved, that goes a long ways. And if there's any reports or information that Centris or your system has, we're certainly available to help, and anything that we can provide, we're certainly happy to do that. And that concludes the presentation. If anybody has questions, I'm happy to answer those. Feel free to type them in. Sure, let me see. I will. All right, your mic has been unclicked.
Hey, thank you. My name is Mike Crosser. I'm one of the pulmonary docs here.
Hey, Dr.
Can you hear me okay?
How are you?
I'm good. So I guess I don't totally understand how the HCCs go to the budgeting of the patient, but not necessarily to the reimbursement to the facility or the physicians. How do the finances work behind this?
Yeah, and I can't speak to your specific arrangements of how that go, but in general terms I can. So the majority of all of our payment models are still based off fee for service, right? So you see a patient, you take care of them, you order and do some stuff, and you get reimbursed based on that. But most contracts have a second element, which is a shared savings. So we'll still get fee for service, or you'll still get your fee for service. But then that second element is, what's say Medicare would say in the ACO, we expect your system to cost us, or to have a budget of $10 million to take care of this attributed Medicare population that you have. And we determined that because your average risk population is a 1.23. So we're setting your budget at 10 million or 100 million, say. But say we were able to come into that at 70 million. So that creates $30 million of potential savings to Medicare. And from that, there's a portion that they would split off and compensate back to the system. So it's really there to offset costs associated with efforts on quality, support if you have a quality component of your contract, and maybe less frequent with specialists, but maybe more so with primary care providers. So it's in supplement to fee for service. Does that help?
Yeah, it does.
Okay.
You mentioned in one of your slides earlier that the HCC codes were only on face-to-face visits.
Yeah.
Was that?
So if you order lab and imaging.
What about telehealth?
Telehealth, thank you. That's a good example. Telehealth counts as that face-to-face visit.
Okay.
I don't know how your practice is right now, but the clinics I work with, we've had a pretty significant slowdown. So it's been good to remind people, hey, during telemedicine visit, if you got extra time, at least you got a patient that you can deal with. Let's try to be comprehensive with it and capture as much as we can on those patients. So kind of taking advantage as we can of this slowdown while it lasts.
Are the HCC scores, is the actual value, is that publicly reported? You mentioned values with a lot of these diagnoses.
Not necessarily. I don't know that it is publicly available. I know that as part of an ACO, you have to report certain information on whether or not you had gains or losses, but I don't think that the risk score of your population is publicized.
No, but as far as certain diagnoses, you know, whether it's pneumonia or, you know, malnutrition, you've reported HCC individual scores, but I've not seen those before.
Yeah, here, I'm gonna pull something up here real quick. So I mentioned the pocket reference guides. Something that we're ready to distribute will be, let me see. I can pull them up on the screen real quick. So pulmonology. So we're going to provide like 20 codes for each specialty.
Got it. That'd be helpful.
Yeah. So if you can see my screen here,
yeah.
Here's some codes that it'll show what the risk adjusted value is. And this was, I think we sat with the chair of the pulmonology department at Advent to come up with this list of high use ones that maybe were underutilized, but it'd be good to know what the risk score would be. So this would tell you what the risk score is. It's a small number, it's kind of manageable, and at least you'll have some orientation of what you're looking for.
Yeah. Although your pneumococcal pneumonia suggests that you have an organism with it. It says pneumococcal there. Okay. I guess, but then underneath it says not, so that's fine.
Okay.
What about is the HCC codes by patient? So if a cardiologist at Shawnee Mission codes for, you know, cardiomyopathy, do I get credit for that, so to speak, and our institution gets credit for that too at KU?
Yeah, so anywhere that the patient is coded with that visit, if they're out in rural Kansas and they have an episode and they go to the hospital and they report a risk adjusted code, it comes back to whatever system that patient is attributed to. And it normally gets attributed to a primary care provider, but there's certainly some specialists who have patients attributed to them as well. So if you're working as a system and your base is your system's primary care providers, everybody's contributing to the codes that make up that average risk score and collectively are responsible for raising it or lowering it depending on their coding patterns.
Is there a way to know which HCC codes I have billed for the year or forgotten to bill for the year?
There is a way to know which HCC codes you have used. It's a little bit more difficult for specialists. You're a pulmonologist. What system are you associated with?
I'm a KU pulmonologist, and I do cystic fibrosis. So I'm probably the primary coder for a lot of the HCC codes for CF patients.
Okay, I can produce a report to show what codes you've used in 2019, and I'm happy to go through it as well. And even do a call with you to say, hey, here's what you used, here's what you didn't use, but I've seen other people use. Is there some substitutions on here that we can look at? If that's something you're interested in, I'm certainly happy to spend the time doing that with you.
Well, and I think I'm a pretty good biller and coder, but just as a system, you know, with all my colleagues who I'm going to try to disseminate this information.
Yeah, and I've done that with some departments. I could work with Joy or with some of the people over there we have a risk adjustment committee that has representation from each system. I'm happy to let them know what you're kind of asking for, and we can come up with a report that would show you that across your entire department.
I'm just certain we're missing important diagnoses that if we knew about it, we would be able to document
and
that.
That's what came up when we met with the pulmonology chief at Advent. He's like, well, this is crazy that we don't capture this. Once you see it, you'll know, and then you can hone in from there.
Yeah, it's like the billing office needs to give an update halfway through the year. Hey, these are the codes that we billed last year that you didn't bill this year on all the patients or something like that, you know?
Sure. I'm happy to get with the people on the RAF committee for Centris at KU, and we can come up with that easily. I'm happy to do that. All I need is an enthusiastic doctor like you, Dr. Crosser.
Well, I have we have a relatively small group, and we're I think in general good documenters. But like in my world, as you mentioned, pancreatic insufficiency is not an HCC, but a pancreatic insufficiency due to cystic fibrosis is an HCC. Right. So there's simple things like that, that if you change the problem list, you'll get it right and you'll get extra points. And presumably that.
Having physician engagement and disseminating this from a physician perspective goes a long ways. It's certainly a lot further than I can do through just a hour-long webinar. And I can get in over my skis pretty quick on getting into the nuanced codes. So it really helps to have a clinician who's an expert on these and sees it every day, take a fresh look at it and understand the data much quicker than it would take us to.
I'm happy to work with anybody to improve our scores here.
Okay, great.
I think that's all the questions I had.
Okay, I appreciate them. Does anybody else have any other questions? Okay, if not, I will conclude the presentation. I want to thank you for taking your lunch hour to work with us. There's a brief 5-question survey at the end of this. If you wouldn't mind taking a few moments to do that, it shouldn't take more than 20 seconds. I would appreciate it. Great, thank you. Have a good afternoon.